Greetings, online students. I'm going to be recording my last lecture, which is going to be over the pituitary gland. I have posted fast fact sheets on the adrenals, the thyroids, and the parathyroids with the answers to my fill-in-the-blanks. If you have any questions at all on that content, then please let me know. It's pretty self-explanatory in the notes, but I'll be happy to go over anything that you don't understand more in depth. All right, then let's get started on the pituitary. And I had it up, and now it's gone. So let's see here. You can see my list is quite lengthy. All right, the endocrine disorders. We're going to start talking about pituitary disorders, and this covers chapter 62, pages 1266 through 72 in your Med-Surg book. And in your PEDS book, there's a little bit in chapter 29. So, when we're talking about the anterior pituitary, we are talking about what it's releasing. And it's releasing several things. The first thing that it is releasing is hormones. And all of these hormones, if you have a complete decrease in any of them, so if let's say you had something wrong with the pituitary gland and you had a decrease in all of these hormones, then that would result in a condition known as Hypopituitarism. Hypopituitarism is when you have a complete decrease in all of the actual pituitary hormones. Now, if you'll remember back in A&P, you start out with the hypothalamus, and the hypothalamus either has releasing or inhibiting factors. For example, let's take growth hormone here. This is what's released from the pituitary gland, is actual growth hormone. But above this is the hypothalamus, and the hypothalamus has growth hormone releasing hormone and growth hormone inhibiting hormone. So depending upon what your level is, the hypothalamus is either going to send, if you need more growth hormone releasing hormone to the pituitary, then it's going to cause release of more, or it's going to send growth hormone inhibiting hormone down to the pituitary and inhibit the release of growth hormone. So the hypothalamus is actually up here somewhere above the pituitary and has an effect on all of the actual hormones secreted from the pituitary gland itself. One of the things you need to keep in mind over here is MSH. MSH is responsible for pigmentation in your body. And what you need to remember is that MSH and ATCH go hand in hand. When one is up, the other one's down. When one is down, the other one's down. So when I have increased ACTH levels, I'm going to have increased MSH levels. When I have decreased ATCH levels, I'm going to have decreased MSH levels. And again, don't forget, I said MSH is responsible for pigmentation. So we're going to talk about disorders that can occur with any of these hormones of your anterior pituitary. Now, your posterior pituitary only releases two hormones that we'll be talking about: ADH, vasopressin, and oxytocin. All right. So what are the causes of disorders of the actual pituitary gland? Well, disorders can be caused by undersecretions, hypofunction, or oversecretions, hyperfunction of any of those hormones I just pointed out. Almost always, if it's a hyperfunctioning organ or gland, it's related to a tumor. If it's a hypofunctioning gland, then it could be an infarct of the pituitary, it could be surgical involvement, it could be something genetic, and it could be tumor tissue pressing on it. But almost always with hyper, it's related to tumors. So let's go on our great adventure, and our first stop is going to be growth hormone and hypo and hypersecretions of growth hormone. Well, first we need to review the functions of growth hormone. And remember, growth hormone is a counter-regulatory hormone, which means it increases glucose levels, remember? So it increases also protein synthesis, the breakdown of fatty acids, glucose levels because it's a counter-regulatory hormone, metabolism, causes cells to grow. That's why when we go through our growth spurts, we have extra growth hormone on board, and it stimulates the liver to produce somatidins. Now, somatidins are enhanced growth activities in your tissues and in your cells, and they're overall responsible for bone and cartilage growth. So let's start with hypopituitarism, or growth hormone deficiency. Now, hypopituitarism means a decrease in one or more of those hormones of the pituitary that was listed, but we're focusing, what if you just have growth hormone deficiency? Deficient secretions of growth hormone in children results in a condition known as, and the answer is, hypopituitarism or dwarfism. Hypopituitarism or dwarfism. This affects about 1 in 10,000 children, so we don't see it very often. It's usually diagnosed earlier in males. Why would that be? And if you think about it, it's because they're going to get evaluated for short stature in males a lot more quickly than they would females. And that has to do with our societal norms. So, talking about the causes, it can be hereditary, it could be tumors, tissues, trauma. Idiopathic, though, is over half the children. Well, idiopathic means we don't have a clue. So in over half of the cases with children with hypopituitarism or dwarfism, we don't know what causes it. And it could be because of pituitary infarction, known as secondary to postpartum hemorrhage, known as Shihan Syndrome. Now, Shihan Syndrome, you don't have to know this for the test, but it's when the pituitary gland, we know it normally changes during pregnancy itself. And when hypotension results from hemorrhage, if you've got someone hemorrhaging postoperatively, ischemia and necrosis of that gland is going to occur because it's going to be without blood. And it develops immediately after delivery usually, but it could be up to years later. Now, there's also something known as psychosocial dwarfism. It's a syndrome of emotional deprivation that actually suppresses the release of growth hormone. And usually if you remove that child from that environment and put them in a more nurturing environment, that syndrome will resolve itself. So manifestations, you need to know these. What would you expect to see? Well, obviously short stature, right? Height retarded more than weight. Immature appearance. Dental eruption is going to be delayed. Hair growth is going to be poor. High-pitched voice, sexual development may be delayed, and development of hypoglycemia. Now, why would they be getting hypoglycemia? Because remember, it is a what? Counter-regulatory hormone. And if you have less of it, it can result in hypoglycemia. All right. In fact, the development of hypoglycemia in an infant might be the first sign of growth hormone deficiency. They may go in for actually signs and symptoms of hypoglycemia and find out that they have hypopituitarism or dwarfism. Diagnostic evaluation, the growth patterns deviate from the norm on the growth chart. This is always a red flag. If you start seeing them falling at the 5th percentile on the growth chart and consistently staying there for height and weight. X-rays. And the definite test right here is based upon what we call a growth hormone level stimulation test. So here's our first stimulation test. And what they're going to do is go in and try to stimulate the body so that it puts it in a condition in which it would expect growth hormone levels to increase. And they do that pharmacologically with different agents. And if the growth hormone level is less than 10 nanograms, then it's considered positive. So in other words, I go in, I try to stimulate growth hormone levels, then they still don't go up when they should go up, then that's considered a positive test, a stimulation test. Now, this agents, I said agents are used. The agents that are used are insulin, which is the most common one, when we have to be very careful because that can induce hypoglycemia. Levodopa, 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 propranolol or beta blocker, propranolol, and clonidine. So these are the agents that are used, and the reason these are used is because when you give these, they affect glucose levels. And what they do is drop glucose levels. Well, if they drop glucose levels, you would expect growth hormone, which is a counter-regulatory hormone, to kick in and help out. But it doesn't if something's wrong with the pituitary and it's not releasing growth hormone like it should. So in the stimulation test, it's going to involve injecting the client with regular insulin and checking the circulating levels of growth hormone. Again, what would you expect to happen after they give insulin? I would expect, with growth hormone being a counter-regulatory hormone, the levels to increase. Because insulin's on board, it's decreasing the glucose level, and it's going to try to help out. But if you give insulin and the growth hormone levels do not increase, then it's positive. If growth hormone levels do increase, then it's negative. If they do increase, it's negative. In other words, it did what it should. You have to be very careful when you're doing this test because you always want to watch for signs and symptoms of hypoglycemia, particularly when you're using insulin. Therapeutic management is treat the cause. Most are unknown, though. Remember, over half is idiopathic. Definite treatment is replacement of the growth hormone. And the drug of choice is somatotropin or somatotropin. And this is really a good drug. It's successful up to 80 to 90% of the time. Usually it's given sub-Q. You may have to alternate sites, and it's given at bedtime because that's going to most closely approximate the physiological release of growth hormone. And at about 9 years of age or so, they should be starting to give their own shots. Now, blood banks do not accept donations from former human growth hormone recipients because of the inability to test for rare neurological degenerative diseases such as CJD. And that stands for Creutzfeldt-Jakob disease or mad cow disease in humans. All right. Nursing considerations. Parents should be told their child will grow the most during the first year. So this isn't a magic thing. They're going to grow. They're going to grow the most in the first year. And how much are they going to grow? 8 to 10 centimeters. Then that's going to decrease. So you need to remember that. Remember, 1 inch is about 2.5 centimeters. So they're going to grow about 4 inches in that first year. So they're going to grow about 4 inches in that first year. Then after, only 1 to 2 inches per year. Then only 1 to 2 inches per year. You need to know this slide. Parents should be encouraged to interact with their child according to their age, not their size, because it would be very easy to do that. Children are made fun of. They need lots of emotional support. They are teased and called names such as short, shrimp, midget, often pick last at sports. So again, emotional support is a must. Now the hormonal replacement can be very expensive, up to $35,000 a year. So we want to make sure that they can be protected and as far as financially and insurance covering it. Community resources, Magic Foundation, Growth Hormone Foundation, and Short Stature Foundation actually will help supplement anything the insurance does not pay. So when would therapy stop and why? Well, I would think if I'm giving someone growth hormone, that eventually, when they've achieved their growth spurt, that's going to kick in. So the period before the epithelial plate closes, because you wouldn't want to keep giving it once that plate closes, or you could result in acromegaly, which is the adult form. So of getting too much. So the period before the epithelial plate closes. The period before the epithelial plate closes. That would be about 14 to 15 in girls and 15 to 16 in boys. And that's again because acromegaly will result if you don't. Acromegaly will result if you don't. So let's talk about hyperpituitarism, growth hormone excess or oversecretion. One example of oversecretion of growth hormone in children, and the main cause of that is tumor. Remember, oversecretion, hypersecretion, main cause is tumors. In the child, it results in gigantism. In the adult, it results in acromegaly, having too much. So now you can see why we quit giving this after the growth plate closes, because then it would be oversecretion of growth hormone, and they would get acromegaly. Manifestations in the child versus the adult. In the child, you're going to see an abnormal increase in long bones, up to 8 feet in height. Height and weight exceed at least 3 standard deviations above the mean. And they end up with a lot of organ enlargement. And actually, this is what ends up causing a lot of their early death. Hypertension, heart failure, delayed fontanelle closures, and again, early death. Acromegaly, the bones actually broaden. They increase in thickness. They increase in width. There's an enlargement in soft tissues and causes a lot of facial changes. There's changes in your ring and your shoe size, and you do need to know that those do not change, even with treatment. Once they get the large feet, the large hands, the long rings, they have acquired these new sizes. Headache, visual problems can result. Usually that's because of the tumor pressing. If you look on page, and I'm sorry, that's not the correct page number, on page 1268, you can see here the progression of acromegaly in figure 62-1. And you can see how the bones have broadened. She's increased in thickness and width. She's had facial changes. And overall, you can see that there has been a significant change throughout her aging process. Diagnostic evaluation, history of excessive growth in childhood. They will be, instead at the 5th percentile, they'll be above the 95th percentile. Increased levels of growth hormone, that's usually greater than 50 nanograms per milliliter, greater than 50 nanograms per milliliter. Normal for children is around 5, so you can see that's significant. Adults 10. X-rays and chest and CT scans to detect tumors. Visual acuity, the tumor may cause pressure on the optic nerve. Let me make sure I said that right. Hold on just a second. Yeah, I thought I said it backwards. Normal in children is less than 10, and in adults less than 5. Sorry about that. Visual acuity, the tumor may actually cause pressure on the optic nerve, so you're going to have visual problems. Enlargement of the sinuses is common because of the broadening of the bones. And instead of doing a stimulation test, now I'm going to do what's called a suppression test, right? If I've got too much of it, then I ought to be able to give something to the patient that normally would suppress growth hormone secretion, right? So in this case, if I gave a glucose load, remember this is a counter-regulatory hormone, so if I gave a glucose load and the glucose level was high, I would expect growth hormone levels to go down because you wouldn't be spitting out more of this, so that would make the levels go up even higher. So what they'll do is go in and do a glucose load, and they'll give like 100 grams of oral glucose, and then they will measure the growth hormone levels up to 120 minutes. Growth hormone levels should go below 5, and if they don't, then that's a positive test in adults, and in children they should go below 10, and if not, that's a positive test in children. Okay, so children, the normal growth hormone levels is 10 nanograms per milliliter, and adults 5 nanograms per milliliter. Therapeutic management, well, the goal is going to be to return hormones back to normal levels or near normal levels. They may have to have surgery, which is the treatment of choice. Radiation is not very helpful at this point. Radioactive implants are common, and pharmacological management. Now, pharmacological management for this includes dopamine antagonists, such as Parladel or Doxanex. In children, high doses of sex steroids to close the epithelial plate have been given. Medications, these medications work by decreasing PRL and growth hormone levels. So one of the side effects that they have that FDA has approved is to decrease growth hormone levels. So a lot of times they will use those prior to surgery to get those levels down to normal. Side effects of these meds are commonly orthostatic hypotension, nausea, vomiting, constipation, headache, and you take them with meals and start with a low dose. Now, of all age groups, adolescents are the most affected by this, and you can imagine why, because of their self-esteem and self-concept that they are building during that time. Now, if they have to have a surgery, they're going to have what's called a transplantinal hypothesectomy, and this is a complete or partial removal of the pituitary gland. And I have included a website, a YouTube link here for you to click on and watch, and please do that so you know what's entailed in this. They can go in intranasally now, or they can cut the upper lip and go in through that way and through the nasal cavity. Preoperative teaching is clean the nasal passage. They're going to get antibiotic spray. They're going to have baseline vital signs and weight, a nasal packing after surgery for 2 to 3 days, and they do need to know potential post-op complications. Now, this is a bad thing because when you take out the pituitary, if they have to have the surgery, then that affects all those other hormones I had listed there. So they'll need supplemental therapy of all of the hormones if you completely take out the pituitary. It is a microscopic surgery that's performed with the client under general anesthesia in a semi-sitting position. The surgeon is going to make an incision just above the upper lip until it reaches the pituitary gland through the sphenital sinuses. And again, this YouTube that I have posted shows you this exactly. And after the gland is removed, a muscle graft can be taken. Often it's off the thigh to support that area and prevent any leakage of cerebral spinal fluid. And then nasal packing is inserted and the incision is closed. And you want to watch for any leakage of cerebral spinal fluid after that. So preoperative teaching, that you're going to go in and teach them before surgery. Don't be afterwards. You can't brush your teeth. Try not to cough and sneeze. Ha. Try not to blow your nose real hard. Bend forward. Anything that's going to increase that pressure. Nasal and mucous membrane swabs are done prior to surgery to make sure they don't have any type of infection. The mustache dressing or the drip pad will be placed under the nose for about 2 to 3 days to make sure that they are not leaking any cerebral spinal fluid. So I said you had to watch them for post-op complications, and the two most common ones that you're going to see is diabetes insipidus, DI, and ICP, increased intracranial pressure. So you're taking care of a patient who's had a transpenial hypothesectomy. You notice the output going up, and they're starting to complain of extreme thirst. That is a red flag of DI, diabetes insipidus, and you probably need to call the MD immediately. Okay. With DI, they can urinate as much as 15 liters a day. So that's why I's and O's, specific gravities, weights are very important. Increase intracranial pressure, you want to watch them for complaints of headaches, nausea, vomiting, visual changes, postnasal drips. You can keep the head of bed slightly elevated, no more than 30 degrees after surgery to help with some of that. You want to monitor that mustache dressing again. It's particularly looking for clear yellow tinged fluid that looks like a halo effect because that could be signs and symptoms of a leaking cerebral spinal fluid. Nuchal rigidity could indicate infection, particularly meningitis, so you want to report that to the physician immediately. Other considerations, you want to encourage fluids. They may have a temporary loss of smell, especially if they've messed with that nerve. O2 and humidification. They'll need mouth care because they can't brush their teeth. Hormonal replacement. Head of bed up, mild analgesics. And to avoid increase in intracranial pressure, teach them not to bend over at the waist. That should be waist, the other waist. Bear down, cough, or lie flat. Anything that would increase intracranial pressure. Watch the child with excessive growth. Emotional support is going to have to be considered. Someone who's adult who keeps complaining of an increase in shoe size, ring size, hat size. And there is an acromegaly network for them as well. Prolactin disorders is another adventure. Where one ends, another begins. So when is it normal to have an increase in prolactin? Of course, it's normal after pregnancy. One normally doesn't see hyposecretions. Usually that's a delayed puberty thing. So if anything, it's usually related to secondary causes like extreme gymnastics. They often have delayed puberty. So usually when we're talking about prolactin, we're talking about hypersecretions. So one of the conditions that you really need to be familiar with is what's called precocious puberty. And it talks about this in your PEDS book, and it's an abnormal early appearance of secondary sex characteristics. Precocious means ripe before your time. So causes idiopathic in 80 to 90% of the cases. In other words, we're not really sure, and then a tumor that can also cause it. There are two types. There is true, complete, or incomplete. True or complete, also known as central, is gonadotropic dependent where you have a premature activation of the hypothalamic pituitary gonadal axis, and that is what controls or puts you in to puberty. So it kind of early activates the puberty system. Incomplete is usually related to something secondary such as tumors. So that tells you right there that the true or complete is the most common. Diagnostic lab values, you would have an increased LH, you would have an increased FSH, and you would have an increased GnRH, gonadotropin releasing hormone. And a lot of times they're going to look at bone age and check them out for bone age to see what is going on. Early manifestations of sexual development in boys before 9 and in girls before 8 and as young as 4. In boys, secondary sexual development before 9, in girls, breast before 7, pubic hair before 8.5, and menses before 9. And now, and keep in the back of your mind, they're having production of mature sperm and ova. The only permanent complication of precocious puberty is short stature. And why is that? Well, if you think about it, they've got excessive sex hormones. So what does the body think? The body thinks at that time that they are in what? Puberty. So what's it going to do to those growth plates? It's going to prematurely close them if we don't fix the problem. And once they're closed, then there goes the growth. Management, if it's incomplete, you want to treat the cause, removal of the tumor. If it's true or complete, daily injections, sub-Q or monthly IM injections of Lupron. You can also give an intranasal spray scenario, but the main one that we use is Lupron. When would treatment be discontinued? Well, it would be discontinued at the time of puberty, right? At about 11 in girls and 12 in boys. It regulates pituitary secretions of LH and FSH, which is your gonadotropin hormones that stimulate the gonads, and it slows the prepubertal growth rate. Okay, so you give the Lupron, and look, what Lupron's going to do is throw them out, keep them from going into early growth spurts. And then once they get to the age 11 or 12, you're going to quit the Lupron and let them naturally close on their own. These children need emotional support. Anytime that you have alterations in your sex hormones, you do need support. You want to teach them about the injections as well, because these are going to cost around $10,000 a year. All right, the posterior pituitary. No adventure would be complete without a stop at the posterior pituitary. And I said there's only 2 hormones in the posterior pituitary, ADH and oxytocin. So you want to remember that the posterior pituitary does not produce hormones. It stores and releases ADH and oxytocin, which is actually produced by the hypothalamus. Now, it's very important that you remember what these do. ADH acts on the kidney tubules to reabsorb water. So that's going to make a lot of difference if I've got too much ADH or I don't have enough ADH, because that's going to regulate how much fluid volume I have. Either I'm going to let too much fluid out or I'm going to retain too much fluid, one or the other, depending upon if I have too much ADH or not enough ADH. Oxytocin stimulates uterine contractions and milk ejection reflex, so that's important during pregnancy. So we're going to focus on ADH. Hypo and hypersecretions of ADH. Well, hyposecretions of ADH result in a condition known as DI, or diabetes insipidus, not to be confused with diabetes mellitus. Diabetes insipidus, DI. And what happens with DI is that it produces a state of uncontrolled diuresis. Well, why is it uncontrolled diuresis? Well, what did we just say that the main function of ADH was? It acts on the kidney tubules to reabsorb water. So if it's not down there at the kidney tubules reabsorbing all that water, what's happening to it? If you're not reabsorbing it, it's going out. So you have uncontrolled diuresis, DI. Now, hypersecretions of ADH result in a condition known as SIADH. SIADH, Syndrome of Inappropriate Antidiuretic Hormone, SIADH. And this results in excessive water conservation. Now I've got too much fluid and I'm retaining too much fluid, just the opposite. The good thing about this is if you understand one of these, you understand the other one because they are the complete opposite. Now, there are 3 types of diabetes insipidus. There's neurogenic, nephrogenic, and psychogenic. Psychogenic is just from compulsive water drinkers that can't control it, and they keep themselves constantly diluted, and they have to have mental concentration. So that leaves us mainly with our neuro and nephro. Now, neurogenic is the most common, and it's a problem with the hypothalamus or the pituitary. Nephrogenic is an inherited disorder where you have something wrong with the renal tubules themselves. In other words, the renal tubules are defected, so it doesn't matter how much ADH I've got down there, they're not going to respond to it. Something's wrong with the renal tubules themselves. With this type, the inherited nephrogenic, if they have that type, then usually they're going to treat them with sodium, protein restrictions, diuretics, and depending upon, it's a fine border of keeping, so they don't have too much fluid, but they've got enough salt. So they are very closely monitored. Neurogenic is the most common one, so that's the one we're going to focus on. Now, normally thirst is regulated by ADH released. ADH facilitates the concentration of urine by stimulating reabsorption of water from the distal tubules of the kidneys. So, when ADH is inadequate or low, the tubules do not reabsorb water, leading to polyuria. Manifestations would be polyuria, nocturia, enuresis in children. Polydipsia, increased thirst, and dehydration. These are the 3 hallmark signs of DI. These are the 3 hallmark signs of DI. Now, this can occur at any age. It usually comes on very suddenly and abruptly, and it leads to dehydration. So, in an infant, what are you going to see? Irritability, that's relieved by feeding of water, not milk. They don't want milk, they want water, they crave it. In the child, excessive thirst. They're drinking 4 to 6 liters a day, and they're voiding 4 to 10 liters in a day. So a lot of bedwetting as well, enuresis that occurs. In an adult, profound urinary output, 5 to 30 liters. Can you imagine? You'd almost have to have a porta potty taped to you. And extreme thirst, 4 to 40 liters, and I can't think of the word. They want cold water. They're going to have weight loss and weakness along with that. So what would you expect the specific gravity and the osmolality of the urine to be? Increased or decreased? And what would you expect the serum osmolality to be? Increased or decreased with DI? Well, we just said with DI, they're putting out massive amounts of urine. And a lot of that is fluid. A lot of that is fluid that they are retaining. So when you're talking about that, if you think about it, the urine's going to be very dilute, so it's going to be decreased. Now, if you think about the serum, they are very dehydrated because they've got all this fluid going out. So it's going to be very increased. So with this one, the urine is decreased osmolality, and the serum is increased osmolality with DI. All right. So what are they going to do for these people? Diagnostic tests. They're going to do what's called the fluid deprivation test. And the simplest test is the simplest test used to diagnose this condition. And what they're going to go and do is restrict oral fluids up to 8 hours or until they lose 5% of their body weight. So they're going to be watching them constantly to make sure they don't lose more than 5% of their body weight. And what they're looking for is changes in urine volume and concentration during the fluid deprivation test. So they're going to assure adequate fluid replacement. They're going to monitor INO daily. They're going to monitor weights and vital signs during this. Hormonal replacement therapy during this time, if they come back positive, is going to be lifelong. So back to the fluid deprivation test. And when you're doing the fluid deprivation test, let me just go back for a second. You really have to watch them closely. They will drink water out of toilet bowls. They will drink out of vases with water in them for plants. They will go up and down the hall and beg people for their drink. They will drink from any source they can find. They get so desperate. And if you think about it, in DI, diabetes insipidus, if I restrict the fluid, is it going to have any effect on the urine formation? No, because it has to do with ADH not being down on the renal tubules, so that if it's not down there, it's not down there, and fluid intake is not going to affect that, other than it's just going to keep on losing fluid. If it's positive, this urine test, let's say they restricted it and it had no or little effect on urine formation, they just kept putting out urine. So if it came back positive, then what you're going to do is give a test dose of ADH, because isn't that what they're missing? ADH. So you'll give 5 units of vasopressin, which is a form of ADH, 5 units of vasopressin. So what should happen now? If I give ADH and that's what they're lacking, now I should start reabsorbing it. So the polyuria, the polydipsia should start reversing itself, correct? But what if I give ADH and it doesn't? Okay, well, the whole problem, Ms. Candler, you said, was they have a decrease in ADH. That's correct. But remember back at the beginning, we said there were 3 types. There was the nephrogenic and the neurogenic. And the nephrogenic had to do with the renal tubules themselves. So if I give ADH and it still does not help, then they probably have the nephrogenic type, that no matter how much ADH I give, it is not going to help. So you have to watch them very closely during this test. We've already talked about watching and monitoring, and we got to hormone replacement therapy, and desmopressin, vasopressin, Ddavp, whichever one you want, as long as it's ADH, is given. And this is the drug of choice, Ddavp. You can give it via nasal spray, oral, or sub-Q. A lot of people get nasal. Side effects include ulcerations of your mucous membranes, allergies, chest tightness, and pulmonary inhalation. And when you take it, it lasts for up to 8 to 20 hours. Now, you want adequate fluid replacement because they're usually dehydrated when the diagnosis is made. You want to monitor, like I said, weight very carefully, because 1 pound can mean 500 mils of retention. Treatment is to increase the dose as needed. And how do I know that? Well, I work on how you do the INOs. If they're starting to put out more and they're starting to have more thirst, I need to increase the dose. If they're decreasing their urinary output and decreasing their thirst, I know the medication is working. Now, if the patient has a respiratory infection, it can interfere with the absorption as well, particularly if you're doing the nasal type. So they would need to report any signs and symptoms of infection to the physician immediately. If I'm giving Ddavp and this is ADH, then what do I have to watch for as the main side effect if I give too much? Well, I would expect overhydration or water intoxication. I would expect going the other way, the opposite way, and I would know that I'm giving too much. Nursing considerations is early detection, medical alert bracelets. With the school-age child, unrestricted use of the lavatory and drinking fountains. During illness, they may need to increase fluids and medications. You probably have to have a doctor's order for that. All right, so the opposite one of that was SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. If you understand DI, you understand this one already, because it's the complete opposite. Now I have an excess of ADH at the renal tubules. And what's the main function of ADH? The reabsorption of water. So now I'm reabsorbing extra water. It can be from all kinds of things. The big thing here, though, usually is tumors. Manifestations, now I've got fluid retention. My sodium levels are going to be less than 120 because I am diluting so much. Abdominal cramps, irritability, headache, personality changes, decreased blood pressure, weight gain. Symptoms disappear when the underlying cause is corrected. Immediate management now is restrict the fluids and diuretics. And usually they're going to be put on a 500 to 800 ml per day restriction. Nursing considerations is daily weights, eyes and nose, monitoring their lab, watching for signs of overload, seizure precautions, support, and assessing mental status. They need to report any weight gain or weight loss. The sodium is going to be so low they may have to, when they first come in, be replaced with hypertonic solutions. Diagnostic test, the sodium levels will be low, just the opposite is what we've seen in DI. They were high because they were extremely dehydrated. Serum osmolality will be decreased with this one, just the opposite, because now they're overhydrated. It was increased with DI because they were dehydrated. Now you will have increased ADH levels, whereas with DI you had decreased ADH levels. And the urine osmolality will be increased now because it's concentrated. You're retaining the fluid. Whereas it was decreased in DI because you were putting out so much. All right. So again, if you got one, you got the other. Not too bad. So when one adventure ends, another begins. So the next stop, go to your adrenal glands, look over those, and if you have any questions or concerns, let me know. Thanks.